Hello guys, we are starting a series of lecture on UWorld QBank for USMLE. This is the portion of cardiology, and in cardiology we have 11 blocks, and each block is having 40 questions. And the way I will explain this, you will love the way, because the way I had highlighted will be very helpful for you, because these are those points which are very close to the exam point of view. So let us start. What will be the method is, you will go to the question. First, you will read this question, then you will answer any one of the option, right? Then after that, you will go to the explanation. Don't worry about the answer which you have opted, either it is wrong or right. We will do it with one another. Okay, so let us start. A 15-year-old boy develops severe cardiomyopathy following myocarditis from Coxsackie virus and is placed on the cardiac transplant list. 2 weeks following his cardiac transplantation from a matched donor, he develops dyspnea on exertion. Extensive evaluation is undertaken, including cardiac catheterization and endomyocardial biopsy to assess for acute allograft rejection. Which of the following histologic findings is the most consistent with this diagnosis? Option A, concentric coronary artery intimal thickening. Option B, dense interstitial lymphocytic infiltrate. Option C, patchy necrosis with granulation tissue. Option D, perivascular infiltrate with abundant eosinophils. Option E, scant inflammatory cells and interstitial fibrosis. Pause it and give the answer. Hope you will have given the answer right. The correct answer is option B. Why? Let us see to the explanation. Since this patient is uh, presented with 2 weeks following his cardiac transplantation from a mate donor, develops dyspnea and exertion. So this is acute allograft rejection, right? Which will be presented less than 6 months, right? So for that, which is acute transplant rejection, which is associated with the uh, cell-mediated immunity. Cell-mediated immunity, particularly the type is T cells, right? And it can be also of the type of antibody, but the predominant one is cell-mediated. So option B is dense interstitial lymphocytic infiltrate, which is predominantly cell-mediated, which is usually presented acutely lymphocytic infiltrate. Right. Why not the other options? The option A, which is the concentric coronary artery intimal thickening. Right. This one, intimal thickening, and with that, this the last option, skin inflammatory cells and interstitial fibrosis. These two options. These are associated with chronic rejection. Right. So option A is not correct because it is associated with chronic, but this case is presented of 2 weeks after rejection, right? So after 2 weeks, the rejection is there. So that's why this is not a chronic. So the chronic, the concentric coronary artery intimal thickening, that is associated with cardiac allograft vasculopathy, but long-term graft dysfunction. Why not option C, patchy necrosis with granulation tissue? This is associated uh, with the donor heart, with the damage to the donor heart, right? When there is ischemia um, of the heart in case of the donor, right? When the donor heart is transplanted to the uh, recipient, during that time, uh, whenever there is ischemia occur, that will present with patchy necrosis with the granulation tissue. It can it can also present acutely, right? So it is also presented acutely. Then why not option D? In option D, we have perivascular infiltrate with abundant eosinophil. Here, note this point eosinophil. This is associated with the hypersensitivity reaction, right? So, whenever there is perivascular infiltrate with abundant eosinophil, this will present with hypersensitivity myocarditis. These are the characteristic of hypersensitivity myocarditis, right? So, the which is the immunologic response to a newly initiated drug, right? So this table is important because this question has been also asked in the uh, immunity uh, section also, right? So you should note these three types of rejections, right? The first one is hyperacute, the second one is acute, and the third one is chronic. Hyperacute, that occurs minutes to uh, hours, right? Then acute, usually less than 6 months. Then we have chronic, which occurs months to years. So uh, these three differences are important. The first one is hyperacute. This is, in this case, what is important is there are preformed recipient antibodies that will attack the graft antigen, right? So preformed antibodies are there. This is important. Thus, in the acute phase, we have both type of immunities, that is cell mediated and humoral or antibody mediated immunity, but the predominant one is cell mediated. This is important. In chronic, we have mixed, that is cell mediated and humoral, right? Okay. What are the morphology in the immunologic section? In the immunity, they have given this MCQ regarding the hyperacute. They were saying that there was the morphology was showing gross mottling and cyanosis. We will go through that. Gross mottling and cyanosis, right? This is important. There will be arterial fibrinoid necrosis with that capillary thrombotic occlusion, right? And this will presented in minutes to hours after transplant. Then we have acute, usually less than 6 months, is in this case, which is presented after 2 weeks of transplant. Okay. In cellular, what will happen is there will be lymphocytic interstitial infiltrate, right? This is important. Lymphocytic interstitial infiltrate and endothelitis. While in case of humoral, humoral is not that much predominant, right? Tau there, but not that much predominant. This cellular one is predominant, right? So in humoral, there will be C4D deposition, there will be neutrophilic infiltrate, and necrotizing vasculitis. Keep in mind this one. This is important. Cellular, lymphocytic infiltrate, right? Then in chronic, which occurs months to years, uh, morphology will be vascular wall thickening, as I mentioned, vascular wall thickening with that luminal narrowing, and interstitial fibrosis and parenchymal atrophy, right? As I mentioned earlier. So let us quickly go through these points. Acute cardiac transplant rejection typically occur within 6 months of transplantation and can be diagnosed via endomyocardial biopsy. Acute rejection can be cell mediated, as I talked about it. Acute cellular rejection, ACR, or less commonly antibody mediated, that is acutely antibody mediated rejection, that is T lymphocytes, which are predominantly which I talked about, right? Which leads to the inflammation and injury to the transplanted organ. Microscopic features are interstitial lymphocytic infiltrate, and with that damaged myocytes, right? Symptoms consistent with progressive rejection found in the systolic dysfunction, that is dyspnea on exertion, right? Then I talked about why not option A, uh, because that is associated with cardiac allograft vasculopathy, right, which is a long-term graft dysfunction. I talked about this. The pathogenesis is the release of cytokines that cause smooth muscle cell proliferation in the vessel wall, right? Uh, the patchy necrosis with granulation tissue is indicative of ischemic damage to the donor heart, which I talked about this. During attempted resuscitation of the donor patient, during transplant of the organ from the donor to the recipient, and acutely during initial perfusion of the organ after transplantation. Then we have perivascular infiltrate with abundant eosinophils, right? This is associated with hypersensitivity myocarditis. I talked about this. Immunologic response to a newly initiated drug. I talked about this, right? Then option E, that is interstitial fibrosis with scant inflammation. They are talking about fibrosis, right? Interstitial fibrosis. So that is the type of chronic rejection of solid organ transplant, right? Mediated by host T cell as well as antibodies. I talked about this, which occurs months to years following transplantation. So what we get at acute cardiac transplant rejection usually occurs weeks to months, right? Weeks to months following transplantation and is primarily cell mediated, right? An acute cellular rejection into myocardial biopsy shows interstitial lymphocytic infiltrate with myocyte damage, right? So we have done the first question. So these are cardiac myocytes, right? These are cardiac myocytes. Then uh, we have interstitial lymphocytic inflammation. They have come and grow uh, uh, and have increased their concentration, right? So this is the interstitial lymphocytic uh, infiltrate, right? Okay. In the next question, please read this question and then pause it and give the answer. Okay. A 54-year-old man is admitted to the hospital due to cough, shortness of breath, and chest discomfort. Right? He has a known history of coronary artery disease and underwent coronary artery bypass graft surgery 3 years ago. As a result of drug therapy, the left ventricular pressure uh, volume loop changes from a solid to a dashed line. Is shown in the graph below. The loop is unchanged in the areas where no dashed line is seen. Okay, which of the following parameters is most likely increased as a result of this change? Read this question. Okay, then give the answer. Okay, so they're talking about that whenever the drug was given, before the drug it was the black one, right? This one. But when they give the drug, then it came over here, right? So we will go to the explanation, right? Okay, so if you look to this graph, right, uh, this point, um, let me explain this on this chart so that it could be easy for you. This one, number 1 point, this is represented this is representing end of diastole, right? End of diastole, right? Or we can say end diastolic volume, right? The first one. Then we have the second point, this one. This is uh, basically representing the aortic wall is open, right? What will happen is, let's say if this is pressure volume uh, uh, curves, if we are moving from this to this, that means the volume is increasing, right? So let's say if here, that is the volume is very low, right? like in this case, the third point, that is called end systolic volume, right? ESV, where the volume is very low, right? Like here and here we can see these are the, because the volume here is the same, right? So uh, we can see when we move from this point till this, the volume is increasing. So till here, this end is the end diastolic volume, which is the uh, maximum volume, right, during diastole, right? So what will happen is when this is gained till this point 1, then whenever it is dilated, right, then the pressure pressure will be increases, and let's say if this is the pressure volume curve for left ventricle, the pressure will increase, will rise, right? Let me clear this so that it could be easily understand. Okay, so when from from here till here, the pressure is rising, right? So what will happen over here, when the pressure is increased, it will open the aortic wall, right? When aortic wall is open, the volume of blood will rush out from the left ventricle, so the volume will decrease go on decreasing, right? So that's why this means that the volume is going on decreasing. Let's say that means it is going in the backward direction, right? So the volume will go on decreasing, right? So then a period will come that there will be the minimum volume, that is called end of systole, right? So then again the pressure will go down, right? Will go down. Okay, then this is the portion, the fourth point, where mitral wall will open, right? Here we're here, if we look to the third point, here the pressure is high, right? So the mitral wall will be closed, right? There will be no flow from uh, left atria to left ventricle. But whenever it is going down, because the pressure is going down, the pressure will get low. It when it gets very low, what will happen is the pressure in the atria will become high from the uh, ventricle. So the mitral wall will gets open, right? So the fluid will go from uh, left atria to left ventricle. So this is the important point which I talked about, right? So okay, so point one, it is in diastolic volume. This is also called preload, uh, which is also represented by end diastolic volume, left ventricular end diastolic volume, or left ventricular end diastolic pressure, right? Okay, then this point, that is aortic wall opens, this point end systolic volume, right? uh, this fourth point, this is representing mitral wall will open. Okay, one other thing, this okay, they have mentioned is this curve is representing compliance, right? And this one curve is representing contractility, right? In this graph, they have mentioned uh, in this graph they have mentioned that let's say if initial contractility was this, right? If initial contractility was this, now it is raised, right? This one, so contractility is increased. And we have read about contractility, that it is uh, the ejection fraction uh, uh, and contractility are correlated. We have read about that which is ejection fraction, which is ejection fraction which is basically the index of contractility, right? जितना ejection fraction ज़्यादा होगा, तो उससे हमें ये पता चल जाता है कि उतना ही contractility ज़्यादा है, right? sorry. uh, from uh, from this relation, we know that uh, whenever the ejection fraction is high, whenever the ejection fraction is high, that is the index of contractility, right? That means when the contractility is more, there will be more ejection fraction, right? Okay, so in this case the ejection fraction is high. Okay, and one more thing is, uh, in this case, if we look to this one, let me highlight this one. This is the end diastolic volume, while this one, that is the end uh, systolic volume, right? Now we have noted that uh, the stroke volume, this is equal to uh, end diastolic volume minus end systolic volume, right? Stroke volume is equal to end diastolic volume minus end systolic volume, right? So um, because in this case the difference is has increased, that means like the end systolic volume has more decreased, right? Due to which the stroke volume is increased, because stroke volume is the difference between these two. Let's say the end diastolic volume initially was 10, right? Minus uh, the end systolic volume initially was 4, so the stroke volume was 6, right? But now in this case, let's say the in this case is the uh, let me try it with another marker. The end diastolic volume is the same, right? But they have mentioned minus that the end systolic volume has decreased, so we will write, let's say if we write 2, okay, so 10 minus 2, that will give us 8. Initially it was 6, right? But now it is 8. So uh, the stroke volume has increased, right? So in the question they're asking about which of the following is most likely increased. So stroke volume is increased, right? If we look to other options, let me remove these things. Let me remove these things for you guys, so that it could be easy. Okay, so okay, in diastolic pressure and in diastolic volume is over here. This region, the first point which we talked about earlier, this is representing the end diastolic volume plus end diastolic pressure. With that, it is also representing compliance. So these three things are the same, because they are talking about that this line is changed by the dash line. So here the dash line is the same. So no change in end diastolic volume or end diastolic pressure or compliance, right? Okay. Why not option B, end systolic volume? End systolic volume has decreased, right? They are asking about increased, right? Parameter most likely increased. They are asking about increase, but here in systolic volume is decreased, so this option is incorrect. We talked about stroke volume, which is increased. Ventricular compliance, we talked about this will remain the same, right? Okay. Preload, we talked about it is representing by the it is represented by the same place of point 1. This is also the same, right? Okay. Now um, okay, so let us have a quick recap to this. The pressure volume loop shifts up and to the left that is increase in cardiac contractility, positive inotropic agent like digoxin and dobutamine, right? Preload, which is 8.1, we talked about this, is unchanged, right? Okay. Uh, and we have increase in contractility, that is increased ejection fraction. We talked about this. That will increases stroke volume. It is the horizontal distance between point 1 and 3. The point 1 is, we talked about this, which is end-diastolic uh, volume, while point 3 is end systolic volume, right? Okay. So then we have, okay, the end systolic volume is decreased, not increased. Okay. Then left ventricular afterload. Afterload, uh, the maximum pressure reached during blood ejection is slightly increased due to the increased in contractility, but this is slightly increased, right? Okay. Then the end diastolic pressure, right, it remains the same, and also with that compliance, okay, there remains the same. Compliance is basically it determines the rate of left ventricular pressure increases is left ventricular volume increases during diastolic filling, right? Compliance is typically unchanged in the short term. This is important. It changes over the long term. Decreased left ventricular compliance occur in concentric left ventricular hypertrophy from prolonged systemic hypertension. This is important, right? So they're talking about decrease in left ventricular compliance would increase the slope of the compliance. That we will talk about this in the above graph, right? Occur an increase in diastolic pressure for the given left ventricular end diastolic volume. They mean to say if there is decrease in left ventricular compliance, what will happen is the slope of the compliance curve will be increased. Let us see. They're talking about this. If let's say uh, if this is the normal compliance, right? If the compliance is decreased, let's say this is the decreased compliance, the slope will be increased. Okay, here the slope is increased. Then on the opposite, if the compliance is increased, right, then the slope will be decreased. They are talking about this thing, right? And the compliance is decreased in uh, they have mentioned this, that the compliance is decreased in concentric left ventricular hypertrophy, and also it is also decreased in other causes of heart failure, right? Okay. So what is the educational objective? An increase in the cardiac contractility shifts the top left corner and to the left, right, and increases stroke volume due to increased ejection fraction. Since the ejection fraction has increased, due to which the stroke volume is also raised, right? Okay, this one is important. The stroke volume is increased because it is the difference between end diastolic volume and end systolic volume. The afterload is little bit increased, right? And with that the contractility is also being increased because the dobutamine uh, and digoxin, these are the drugs which increase heart contractility, right? Okay, good. Then we have uh, in case of uh, diastolic heart failure, as I mentioned about this, the contractility is preserved, but the compliance will be decreased, right? But the compliance will be decreased. Or what will happen is as I mentioned, the uh, uh, the slope will be increased. Like let's say the normal slope is this one, which is the normal compliance, right? But now the compliance is decreased, so the slope is increased, right? They're talking about this thing. Okay. Now let us move to the next question. Uh, the same way you will do. Okay. A 64-year-old man presents to the office with a chest discomfort and mild shortness of breath that started 1 hour ago after an argument with his wife. He has a long history of hypertension and diabetes mellitus. His BP is 180 by 100 mm of Hg and his heart rate is 100 uh, per minute. An EKG takes an EKG taken in the emergency department shows no signs of acute ischemia. Cardiac auscultation in the left decubitus position and full expiration reveals a presystolic sound. Which of the following best explains the physical examination finding? Option A, papillary muscle dysfunction. Option B, left ventricular hypertrophy. Option C, increased left ventricular preload. Option D, aortic regurgitation. Option E, mitral leaflet fusion and fibrosis. Pause it and give the answer. Right. Okay. This is the position, the left lateral recumbent. Right. It is left decubitus position, the blue one. Right. Okay. So the correct answer is increased left ventricular hypertrophy. And the presystolic sound, this is they have mentioned this one, the presystolic sound. Basically, presystolic sound is late diastolic sound, and it is uh, also called is S4 sound, right? So which is due to since they have mentioned long history of hypertension. This hypertension will lead to uh, left ventricular hypertrophy, right? And that will produce presystolic sound. So the correct option is left ventricular hypertrophy. Why not the other options? Right, we will discuss each and every one. Why not option A? Because papillary muscle dysfunction. This is usually uh, associated with murmur heart sound, not presystolic sound. Okay, why not the other option like C? Okay, increased left ventricular fluid. This is usually not associated with a characteristic type of sound, heart sound, right? Then we have aortic regurgitation. This is associated with early decrescendo and mid diastolic uh, murmur, right? But not associated with presystolic sound. Then we have mitral leaflet fusion and fibrosis. That will lead to uh, mitral stenosis, and due to which it will produce murmur sound. Okay, not presystolic sound. Now let us see to the explanation. So as I mentioned, why not option A? That is murmur sound due to uh, incomplete closure of AV valves, right? That is the S4 sound is also called presystolic sound or late diastolic sound. Okay, then why not? Okay, about B I talked about, that is presystolic or late diastolic sound. Uh, it is associated with left ventricular hypertrophy and other causes of heart failure, right? Then why not option C? That is increased left ventricular preload doesn't result in any characteristic heart sound. I talked about this. Aortic regurgitation, RD decrescendo, and mid diastolic murmur. I talked about this. Mitral leaflet fusion and fibrosis, mitral stenosis, mid diastolic murmur plus possible is for sound due to contraction of the atria. Let us see to the explanation in a quick way. Is for isolated presystolic late diastolic um, heart just prior to S1. S4 is caused by left atrial contraction. This is important. S4 is caused by left atrial contraction. That force is aerial blood into the poorly compliant left ventricle, right? That is nearly filled to a capacity because of hypertrophy. Okay, Um, left ventricular hypertrophy, and other causes of diastolic heart failure therefore favor generation of S4 sound, right? This patient left ventricular hypertrophy is likely secondary to chronic hypertension, as I talked about earlier. Okay, Weiner option A causes incomplete closure of the AV valves. We talked about this murmur audible during systole, right? Option C, that is increase in left ventricular plea load, not a result in a characteristic heart sound. I talked about this, right? Aortic regurgitation, that is decrescendo early mid diastolic murmur, mitral leaflet fusion and fibrosis that will lead to mitral stenosis that will produce mid diastolic murmur. With that, possible late diastolic, that is pre-systolic as intuition due to atrial contraction. That means it can also lead to S4 sound, but most commonly that is associated with left ventricular hypertrophy, right? So this is important. An S4 sound is best heard near the cardiac apex, left lateral decubitus position, result from the atrial contraction, which forces blood into the left ventricle. That is reach its limit of compliance, right? Chronic hypertension uh, causes left ventricular hypertrophy, which itself may promote the generation of NS4 sound. Okay, I think it's enough for today. We will continue from uh, question 4. What we will do is we will uh, finish one block in a week roundabout. What For today we do 3 questions, but we will increase this speed, right? What we will do uh, 7 questions per day, so that it could become seven that could become uh, uh, 42 question per week, right? In 6 days that will uh, become 72, sorry, in 6 days that will become 42 question. So that will be very good for us, that when we do one block per week, right?